Welcome back, future nurses. Today we're tackling one of the toughest parts of the NCLEX, select all that apply questions on pregnancy. These aren't your regular questions, these are the critical thinking, high-stakes scenarios that the exam loves to throw at you. By the end of this video, you'll not only test your knowledge but also learn how to break down SATA questions step by step, so you can walk into your exam with confidence. Grab your notebook, stay focused, and let's dive right in. Question 1. A client at 34 weeks gestation has sudden vaginal bleeding. Which findings support placenta previa? Select all that apply. A. Bright red, painless bleeding. B. Firm, tender, hypertonic uterus. C. Cervical dilation noted on exam. D. Fetal heart rate remaining reassuring. E. Fetal presenting part palpated high and mobile. F. Maternal abdominal guarding and rebound tenderness. Answer, A, C, D, E. Rationale, previa placenta over/near cervix causing bright, typically painless bleeding, exam may reveal cervical change, presenting part may be high, placenta between fetus and cervix. Tender, hypertonic uterus and guarding suggest abruption or peritonitis, not previa. Strategy, if bleeding is painless and presenting part is high, suspect previa. Question 2. Which findings indicate placental abruption? Select all that apply. A. Sudden severe, constant abdominal pain. B. Dark, concealed bleeding with hypotension. C. Soft, non-tender uterus. D. Uterine tachysystole with hypertonus. E. Fetal bradycardia or late decelerations. F. Painless, recurrent bright bleeding. Answer, A, B, D, E. Rationale, abruption painful, often concealed bleeding causing maternal hypotension, rigid hypertonic uterus, and fetal distress. Soft non-tender uterus and painless bright bleeding are more consistent with previa. Strategy, pain plus uterine rigidity plus fetal distress equals abruption. Question 3. A pregnant client has severe preeclampsia. Which assessments/interventions are appropriate? Select all that apply. A. Give 4 magnesium sulfate as ordered. B. Encourage ambulation to reduce edema. C. Monitor deep tendon reflexes hourly. D. Obtain hourly urine output and protein quantification. E. Place client flat supine to improve perfusion. F. Prepare for possible urgent delivery if status worsens. Answer, A, C, D, F. Rationale, MgSO4 prevents seizures, monitor DTRs for toxicity, urine output/protein assess renal involvement, severe preeclampsia may require expedited delivery. Ambulation and supine positioning can worsen hypotension and cerebral perfusion, avoid. Strategy, treat severe preeclampsia like multi-organ risk, monitor closely and prepare for delivery. Question 4. Which patient teaching is correct for oral iron therapy in pregnancy? Select all that apply. A. Take iron with orange juice or vitamin C source. B. Take with milk to minimize GI upset. C. Expect stools to become darker, this is harmless. D. If constipation occurs, discuss stool softener/fiber with provider. E. Antacids can be taken with iron to reduce nausea. F. Best absorbed when taken with tea to prevent staining. Answer, A, C, D. Rationale, vitamin C enhances absorption, dark stools are common, constipation is expected and managed with diet/approved laxatives. Milk, antacids, and tea reduce iron absorption or interfere, they should be avoided near dosing. Strategy, pair iron with vitamin C, avoid calcium/antacids/tea near doses. Question 5. Which signs/symptoms should a client at 28 weeks immediately report? Select all that apply. A. Sudden severe headache unrelieved by acetaminophen. B. New onset visual disturbances, spots, blurring. C. Mild ankle swelling after standing all day. D. Decrease in fetal movement compared with normal baseline. E. Intermittent shortness of breath when climbing stairs. F. Vague epigastric discomfort after a large meal. Answer, A, B, D. Rationale, Headache and visual changes indicate possible severe preeclampsia, decreased fetal movement signals fetal compromise. Mild dependent edema and exertional dyspnea are often normal in pregnancy. Epigastric discomfort after meals less concerning and less severe/persistent. Could be severe preeclampsia sign if persistent/worsening. Strategy: report neurologic changes and fetal movement. These are red flags. Question 6. Which are appropriate interventions for preterm labor at 31 weeks with intact membranes? Select all that apply. A. Administer betamethasone as ordered. B. Immediate placement in Trendelenburg to stop labor. C. Start tocolytics if no contraindications. D. Begin magnesium sulfate for fetal neuroprotection if delivery expected. E. Encourage immediate ambulation to test contraction persistence. F. Obtain cultures and start broad-spectrum antibiotics for chorioamnionitis prophylaxis. Answer: A, C, D. Rationale: steroids accelerate fetal lung maturity, tocolytics may delay labor, MGSO4 offers neuroprotection before very preterm birth. Trendelenburg and ambulation are contraindicated, antibiotics only indicated if infection suspected, not routine prophylaxis. Strategy: for preterm labor, delay delivery plus protect fetus, steroids, tocolysis, MG. Question 7. Which findings are most consistent with ectopic pregnancy? Select all that apply. A. Missed menses, then unilateral lower quadrant pain. B. Shoulder tip pain with abdominal rigidity. C. Rising quantitative beta-HCG at expected doubling pattern. D. Light, irregular vaginal spotting rather than heavy flow. E. Enlarged uterus on abdominal exam consistent with last LMP date. F. Signs of hypovolemia, tachycardia, hypotension, with peritoneal signs. Answer: A, B, D, F. Rationale: ectopic classically causes missed menses, unilateral pain, referred shoulder pain from hemoperitoneum, light irregular spotting, and can rupture causing hypovolemia. A normally rising HCG doubling and appropriately enlarged uterus point to intrauterine pregnancy. Strategy: think missed period plus unilateral pain plus spotting plus possible shoulder pain ectopic until proven otherwise. Question 8. A client with gestational diabetes, diet controlled, seeks advice. Which statements are accurate? Select all that apply. A. Monitor fasting and postprandial blood sugars per schedule. B. Avoid all carbohydrates, go zero carb to prevent hyperglycemia. C. Aim for consistent carbohydrate distribution across meals. D. Check fetal movements less frequently due to maternal glucose control. E. Exercise after meals may help lower postprandial glucose. F. Request insulin immediately if diet fails, since oral hypoglycemics are preferred. Answer: A, C, E. Rationale: monitoring is essential. Consistent carb distribution and post-meal activity help control postprandial glucose. Zero carb is unsafe for pregnancy. Oral hypoglycemics are not universally preferred. Insulin is gold standard when diet fails. Fetal movement monitoring should remain normal. Strategy: GDM equals monitor plus diet consistency plus exercise. Escalate to insulin if needed. Question 9. Which are immediate nursing actions for suspected umbilical cord prolapse during labor? Select all that apply. A. Call for help and notify provider immediately. B. Apply sterile saline moistened towel to exposed cord. C. Push fetal presenting part upward off the cord and maintain pressure. D. Place client in Trendelenburg or knee chest position to relieve cord compression. E. Apply fundal pressure to speed delivery. F. Prepare for immediate cesarean delivery if cord compression persists and fetus compromised. Answer: A, B, C, D, F. Rationale: cord prolapse requires immediate action, call for help, keep cord moist, relieve pressure, manual upward displacement, position to reduce compression, and prepare for emergency delivery. Fundal pressure worsens cord compression, do not apply. Strategy: prioritize relief of cord compression plus rapid delivery. Question 10. Which non-pharmacologic measures effectively reduce labor pain? Select all that apply. A. Patterned breathing and relaxation techniques. B. Continuous hydrotherapy, shower or tub, in active labor as appropriate. C. Systemic opioids early in first stage for all clients. D. Frequent position changes and upright positioning in active labor. E. Transcutaneous electrical nerve stimulation, TENS, at dermatomal sites. F. Application of cold packs to perineum during second stage. Answer: A, B, D, E, F. Rationale: breathing, water therapy, position changes, TENS, and cold/heat are non-pharmacologic tools. Systemic opioids are pharmacologic and have fetal/maternal effects, not non-pharmacologic. Strategy: use multimodal non-drug techniques, choose methods matching labor stage and client preference. Question 11. A postpartum client is being discharged after cesarean. Which instructions are important regarding wound care and prevention of infection? Select all that apply. A. Keep wound clean and dry, shower and pat dry daily. B. Rub antiseptic ointment into incision every 6 hours without provider order. C. Report fever greater than 38 degrees Celsius 100.4 degrees Fahrenheit or increased redness/drainage. D. Remove steri-strips as soon as they become wet or loose at home. E. Avoid heavy lifting, greater than 10 pounds, for the first 6 weeks or as directed. F. Skip follow-up appointment if incision appears fine. Answer: A, C, E. Rationale: clean, dry care, report fever or signs of infection, avoid heavy lifting to permit healing. Unprescribed topical medications and unadvised removal of dressings can impair healing, never skip follow-up. Strategy: post C-section care equals protect incision plus watch for infection plus limit strain. Question 12. Which maternal conditions increase the risk for intrauterine growth restriction, IUGR? Select all that apply. A. Chronic hypertension. B. Maternal smoking and substance use. C. Gestational diabetes with poor control resulting in hyperglycemia. D. Placental insufficiency or abruption. E. High maternal BMI with well-controlled metabolic status. F. Severe maternal malnutrition. Answer: A, B, D, F. Rationale: hypertension, smoking/substance use, placental issues, and malnutrition restrict fetal growth. Poorly controlled gestational diabetes often leads to macrosomia, large baby, not IUGR. High BMI with good control is less likely to cause IUGR. Strategy: risk for IUGR equals any condition that reduces placental perfusion or nutrient delivery. Question 13. Which action should the nurse take for a client with PPROM, preterm premature rupture of membranes, at 33 weeks without labor or infection? Select all that apply. A. Administer betamethasone per protocol for lung maturity. B. Immediately induce labor to reduce infection risk. C. Give latency antibiotics to reduce chorioamnionitis risk if ordered. D. Encourage immediate ambulation to enhance fetal descent. E. Monitor maternal temperature and fetal status frequently. F. Begin tocolytics to absolutely stop any contractions. Answer: A, C, E. Rationale: PPROM management often includes steroids, antibiotics for latency, and close monitoring. Immediate induction is not always indicated if no labor/infection. Ambulation may increase risk of labor/infection. Tocolytics are not routinely used in PPROM and may be contraindicated. Strategy: PPROM equals protect fetal lungs plus prevent infection plus watch closely. Question 14. Which clinical features are typical of HELLP syndrome, a variant of severe preeclampsia? Select all that apply. A. Hemolysis on labs, elevated bilirubin, low haptoglobin. B. Elevated liver enzymes, AST/ALT. C. Platelet count 100,000/mm superscript 3. D. Polyhydramnios on ultrasound. E. Right upper quadrant or epigastric pain. F. Persistent hyperthermia, greater than 39 degrees Celsius. Answer: A, B, C, E. Rationale: HELLP equals hemolysis, elevated liver enzymes, low platelets, often with RUQ/epigastric pain. Polyhydramnios and high fever are not classic features. Strategy: if preeclampsia plus RUQ pain plus abnormal labs, suspect HELLP. Question 15. Which newborn risks are associated with maternal chorioamnionitis? Select all that apply. A. Early onset neonatal sepsis. B. Respiratory distress in the neonate. C. Lower risk of neonatal complications due to maternal antibiotics. D. Need for NICU observation and empiric antibiotics at times. E. Prolonged neonatal hyperglycemia due to maternal infection. F. Increased risk of cerebral palsy with severe neonatal infection. Answer: A, B, D, F. Rationale: chorioamnionitis increases risk of early sepsis, respiratory compromise, NICU care, and severe infection can be linked to later neurodevelopmental issues. Maternal antibiotics reduce but do not eliminate neonatal risk. Hyperglycemia is not a direct typical outcome. Strategy: suspected chorioamnionitis, anticipate neonatal sepsis workup and monitoring. Question 16. Which maternal signs suggest magnesium sulfate toxicity during seizure prophylaxis? Select all that apply. A. Absent deep tendon reflexes. B. Respiratory rate less than 12 breaths/min. C. Profound hypotension and bradycardia. D. Urinary output greater than 100 milliliters per hour. E. Flushing and sweating as early mild signs. F. Slurred speech and blurred vision. Answer: A, B, C, F. Rationale: MG toxicity, loss of DTRs, respiratory depression, hypotension/bradycardia, CNS depression, slurred speech/visual changes. High urine output is protective. Flushing can be a transient side effect but not a reliable toxicity sign. Strategy: monitor DTRs, RR, BP, and urinary output while on MG. Stop an antidote, calcium gluconate, if signs of toxicity. Question 17. Which are appropriate nursing measures for postpartum hemorrhage due to uterine atony? Select all that apply. A. Massage the fundus firmly until it remains contracted. B. Encourage the client to void and assess bladder distension. C. Promptly administer uterotonic drugs as ordered, e.g., oxytocin. D. Place the client flat and elevate legs only if hypovolemic. E. Avoid giving fore fluids as they may dilute clotting factors. F. Prepare for blood transfusion if bleeding does not respond. Answer: A, B, C, F. Rationale: fundal massage, bladder emptying, uterotonics, and transfusion preparation are correct. For fluids are essential for hypovolemia, contrary to E. Flat position with legs up can be used if hypovolemic, but overall stabilization and ABCs are priority. Strategy: PPH, contract the uterus plus control bleeding plus support circulation. Question 18. Which prenatal vaccinations are recommended and safe during pregnancy? Select all that apply. A. Inactivated influenza vaccine, any trimester. B. Live attenuated MMR vaccine during pregnancy. C. Tdap between 27 to 36 weeks in each pregnancy. D. Varicella vaccine during pregnancy if not immune. E. COVID-19 mRNA vaccine per current recommendations. F. HPV vaccine during pregnancy. Answer: A, C, E, depending on current public health guidance. Rationale: inactivated flu and Tdap are routinely recommended. COVID-19 mRNA vaccines are widely recommended, check current guidance. Live vaccines, MMR, varicella, HPV, are contraindicated in pregnancy. Note: always follow current national guidelines. Strategy: during pregnancy, inactivated vaccines that protect mother/newborn are recommended, avoid live vaccines. Question 19. Which antepartum findings increase the likelihood of oligohydramnios? Select all that apply. A. Rupture of membranes with prolonged leakage. B. Fetal renal agenesis detected on ultrasound. C. Maternal polyuria from uncontrolled diabetes. D. Posterior placenta location on ultrasound. E. Use of ACE inhibitors during pregnancy. F. Placental insufficiency leading to decreased fetal urine output. Answer: A, B, E, F. Rationale: ROM, renal anomalies, ACE inhibitors, renal impairment, and placental insufficiency reduce amniotic fluid. Maternal polyuria increases fluid but does not directly cause oligohydramnios. Placenta location does not cause oligohydramnios. Strategy: oligohydramnios equals reduced fetal urine output or leaking fluid. Question 20. Which behaviors should be included in teaching to reduce neural tube defect risk? Select all that apply. A. Begin folic acid 0.4 to 0.8 mg daily preconception and early pregnancy. B. Avoid folic acid, it has no proven benefit for neural tube defects. C. Use alcohol sparingly during the first trimester only. D. Manage pregestational diabetes and achieve good glycemic control preconception. E. Take high doses of vitamin A, retinoids, for skin benefits while planning pregnancy. F. Consider higher folic acid dosing, e.g., 4 mg, if prior neural tube defect pregnancy. Answer: A, D, F. Rationale: folic acid before and during early pregnancy reduces neural tube defects. Diabetes control decreases teratogenic risk. High-risk women, prior NTD, require higher folic acid dosing as directed. Alcohol and high vitamin A, retinoids, are contraindicated. Strategy: preconception folate plus metabolic control are key to prevention. Question 21. Which clinical findings suggest postpartum endometritis? Select all that apply. A. Uterine tenderness and subinvolution. B. Foul-smelling lochia and fever. C. Severe perineal pain with purulent drainage from episiotomy site. D. Elevated WBC and tachycardia. E. Profuse, painless vaginal bleeding immediately postpartum. F. Pain relieved by ambulation and heat pack. Answer: A, B, D. Rationale: endometritis presents with fever, uterine tenderness, foul lochia, elevated WBC, and tachycardia. Purulent drainage at an episiotomy suggests local wound infection, not primary endometritis. Profuse painless bleeding is PPH. Pain relieved by ambulation is not specific to endometritis. Strategy: fever plus uterine tenderness plus foul lochia postpartum suspect endometritis. Question 22. Which findings are expected with hydatidiform molar pregnancy? Select all that apply. A. Markedly elevated beta-HCG for gestational age. B. Uterus small for dates and decreased bleeding. C. Snowstorm pattern on ultrasound without identifiable fetus. D. Severe nausea and hyperemesis gravidarum. E. Early onset severe hypertension and sometimes hyperthyroidism. F. Low risk of choriocarcinoma after molar evacuation. Answer: A, C, D, E. Rationale: complete mole shows very high HCG, snowstorm ultrasound, severe N/V, early HTN, and hyperthyroid symptoms. Uterus is usually large for dates. There is a risk, not low, of persistent trophoblastic disease/choriocarcinoma. Follow-up HCG monitoring is essential. Strategy: excessively high HCG plus abnormal ultrasound equals molar pregnancy. Follow HCG until negative. Question 23. Which interventions reduce vertical transmission of HIV from mother to newborn? Select all that apply. A. Maternal antiretroviral therapy during pregnancy and labor. B. Routine invasive procedures like fetal scalp electrodes regardless of status. C. Administer zidovudine to the newborn per protocol after delivery. D. Offer elective cesarean at 38 weeks if viral load is high near delivery. E. Avoid breastfeeding if safe formula feeding is available and recommended locally. F. Delay maternal ART until after delivery to avoid fetal drug exposure. Answer: A, C, D, E. Rationale: maternal ART, neonatal prophylaxis, cesarean for high viral load, and avoidance of breastfeeding where safe alternatives exist reduce transmission. Invasive fetal monitoring increases transmission risk and should be minimized. Delaying ART is unsafe. Strategy: To reduce vertical transmission, treat mom plus protect baby plus minimize invasive exposures. Question 24. Which are warning signs of postpartum depression rather than baby blues? Select all that apply. A. Emotional lability and tearfulness for 2 days postpartum. B. Persistent inability to sleep even when baby sleeps, lasting 2 weeks. C. Thoughts of harming self or baby. D. Inability to bond with baby and persistent hopelessness. E. Mild transient anxiety that improves with rest and support. F. Interest in self-care returning after 1 week. Answer: B, C, D. Rationale: blues are transient, self-limited. Persistent insomnia, intrusive homicidal/suicidal thoughts, inability to bond, and ongoing hopelessness indicate postpartum depression or psychosis and require immediate intervention. Strategy: any persistent functional impairment or dangerous thoughts, urgent evaluation. If you're enjoying this video so far, like and subscribe. Question 25. Which features on fetal monitoring are concerning for uteroplacental insufficiency? Select all that apply. A. Late decelerations occurring with contractions. B. Moderate variability with accelerations present. C. Prolonged bradycardia below baseline for 3 minutes. D. Variable decelerations with rapid return to baseline and moderate variability. E. Absence of accelerations over prolonged testing in a fetus expected to be reactive. F. Sinusoidal pattern with little variability. Answer: A, C, E, F. Rationale: late decelerations, prolonged bradycardia, non-reactive NST, no accelerations, and sinusoidal patterns indicate fetal compromise/insufficiency. Moderate variability with accelerations and isolated variable D cells with good variability are less immediately ominous. Strategy: look for patterns showing hypoxia, late D cells, absent variability, sinusoidal. Question 26. Which medications are contraindicated or require extreme caution in pregnancy? Select all that apply. A. Isotretinoin, oral retinoid, for severe acne. B. ACE inhibitors, e.g., lisinopril, for chronic hypertension. C. Low-dose aspirin, 81 mg, for preeclampsia prevention in high-risk women. D. Methotrexate for autoimmune disease flare control. E. Ondansetron, Zofran, as first-line antiemetic without discussion of risks. F. Heparin, LMWH, for DVT prophylaxis when indicated. Answer: A, B, D, E, caution/discuss risks. Rationale: isotretinoin and methotrexate are teratogenic, ACE inhibitors cause fetal renal damage. Low-dose aspirin and LMWH are used when indicated. Ondansetron use should be considered with current evidence and local guidelines. It's often used but with counseling. Strategy: avoid known teratogens, use indicated meds, aspirin, heparin, when benefits outweigh risks. Question 27. Which maternal behaviors/conditions increase risk of preterm premature rupture of membranes, PPROM? Select all that apply. A. Smoking during pregnancy. B. History of cervical circlage removal at term. C. Prior PPROM or preterm birth history. D. Short cervical length on ultrasound in mid-trimester. E. Routine sexual intercourse at term without complications. F. Maternal periodontal disease and infections. Answer: A, C, D, F. Rationale: smoking, prior PPROM/preterm birth, short cervix, and maternal infections increase PPROM risk. Routine, uncomplicated intercourse at term is not a major risk factor. Circlage removal at term is not a risk by itself. Strategy: prevention targets modifiable risks, stop smoking, treat infections, and monitor high-risk cervix. Question 28. Which signs suggest amniotic fluid embolism, AFE, during labor or immediately postpartum? Select all that apply. A. Sudden respiratory distress and hypoxia. B. Abrupt hypotension and cardiovascular collapse. C. Disseminated intravascular coagulation, bleeding from multiple sites. D. Gradual onset mild fever and uterine tenderness over days. E. Fetal heart rate remaining perfectly stable throughout event. F. Seizure activity or altered mental status in mother. Answer: A, B, C, F. Rationale: AFE presents catastrophically with sudden hypoxia, hypotension, DIC, and CNS changes. Gradual fever and uterine tenderness suggest infection, not AFE. Fetal status may deteriorate secondary to maternal collapse. Strategy: AFE is a medical emergency, rapid CPR, oxygenation, and critical care measures are required. Question 29. Which factors increase the risk of shoulder dystocia during vaginal birth? Select all that apply. A. Fetal macrosomia, estimated large fetal size. B. Maternal obesity and diabetes. C. Prolonged second stage of labor. D. Active management with oxytocin augmentation only. E. Instrumental delivery, forceps/vacuum, in a large baby. F. Maternal short stature and small pelvis. Answer: A, B, C, E, F. Rationale: macrosomia, maternal diabetes/obesity, prolonged second stage, instrumental delivery, and pelvic constraints increase shoulder dystocia risk. Oxytocin by itself does not directly cause dystocia but may be part of labor augmentation leading to complications. Strategy: anticipate dystocia in large babies or biomechanical risk and prepare maneuvers. Question 30. Which maternal lab findings are consistent with HELLP syndrome? Select all that apply. A. Elevated AST/ALT. B. Platelets 70,000/mm superscript 3. C. Elevated LDH and evidence of hemolysis on smear. D. Serum creatinine within normal non-pregnant limits only. E. Markedly low fibrinogen indicative of DIC in all HELLP cases. F. Mildly elevated AST only with normal platelets and no hemolysis. Answer: A, B, C. Rationale: HELLP shows elevated liver enzymes, thrombocytopenia, hemolysis with elevated LDH. Creatinine may be elevated if renal involvement, fibrinogen may decrease if DIC develops but is not a constant HELLP finding. Isolated AST elevation without other components does not meet HELLP criteria. Strategy: HELLP equals triad of hemolysis, elevated liver enzymes, low platelets. Question 31. Which are priorities when caring for a client with severe hyperemesis gravidarum? Select all that apply. A. Correct dehydration with 4 fluids and electrolytes. B. Encourage oral intake only, avoid IV therapy unless delivery imminent. C. Administer antiemetics per protocol, e.g., vitamin B6, doxylamine. D. Monitor weight and urine ketones for nutritional status. E. Start enteral tube feeding as first line immediately postpartum. F. Evaluate for psychosocial stressors but prioritize physiologic stabilization. Answer: A, C, D, F. Rationale: hydration, electrolytes, antiemetics, and monitoring nutrition are key. Enteral/parenteral nutrition considered if conservative measures fail. Psychosocial evaluation is helpful but physiologic stabilization comes first. Strategy: treat dehydration and electrolyte imbalance first, then address nutrition and causes. Question 32. Which interventions decrease risk of Group B streptococcus, GBS, vertical transmission? Select all that apply. A. Screen all pregnant women for GBS at 36 to 37 weeks and give interpartum antibiotics if positive. B. Give interpartum antibiotics only if the mother has fever, irrespective of GBS status. C. Administer interpartum 4 penicillin to colonized mothers during labor. D. Perform immediate C-section for GBS colonization detected prenatally. E. Do not skin-to-skin contact after birth if mother is GBS positive and untreated in labor. F. Provide neonatal observation and empiric antibiotics based on risk factors and clinical signs. Answer: A, C, E, F. Rationale: screening and appropriate interpartum antibiotics reduce neonatal early-onset GBS disease. C-section is not required solely for colonization. If mother is untreated in labor and newborn at risk, observation and possibly empiric antibiotics are indicated. Temporary precautions like delayed skin-to-skin may be considered per protocols. Strategy: prevent neonatal GBS through screening plus intrapartum antibiotics when indicated. Question 33. Which are accurate statements about pregnancy and thyroid disease? Select all that apply. A. Overt hyperthyroidism increases risk of miscarriage and preterm birth if uncontrolled. B. Radioactive iodine treatment is safe during pregnancy for hyperthyroidism. C. Hypothyroidism in pregnancy untreated increases risk of cognitive deficits in the child. D. Levothyroxine dosing often needs to be increased during pregnancy for hypothyroid women. E. TSH naturally rises in the first trimester and should not be interpreted against trimester-specific ranges. F. Antithyroid medications may be used carefully, e.g., PTU in first trimester, methimazole later, under specialist guidance. Answer: A, C, D, F. Rationale: uncontrolled thyroid disease is harmful, levothyroxine dose adjustments are commonly required. Radioactive iodine is contraindicated. TSH interpretations require trimester-specific ranges. TSH often decreases in first trimester due to HCG. Antithyroid meds are used cautiously with specialist oversight. Strategy: manage thyroid disease actively during pregnancy to protect maternal and fetal outcomes. Question 34. Which findings increase suspicion for gestational trophoblastic neoplasia, post-molar disease, after molar evacuation? Select all that apply. A. Plateaued or rising beta-HCG titers after evacuation. B. New abnormal uterine bleeding weeks after evacuation. C. Rapid decline to undetectable beta-HCG within 2 weeks post-evacuation. D. Evidence of metastatic lesions, e.g., persistent cough, hemoptysis. E. Persistent abdominal pain and enlarging uterine size. F. Immediate normalization of menstrual cycles within days. Answer: A, B, D, E. Rationale: plateau or rise of HCG, persistent bleeding, enlarging uterus, or metastases suggest persistent trophoblastic disease requiring oncology follow-up. Rapid decline to undetectable HCG is desired, immediate normal cycles are not expected. Strategy: post-molar follow-up equals serial HCGs until negative and monitor symptoms. Question 35. Which are priorities in the management of severe antepartum hemorrhage? Select all that apply. A. Establish large bore 4 access and begin fluid resuscitation. B. Perform bedside manual removal of the placenta in all cases. C. Cross-match blood and prepare for transfusion as needed. D. Continuous fetal monitoring and assess for fetal distress. E. Delay surgical consultation until imaging confirms diagnosis in stable patients. F. Place the patient in left lateral tilt to maximize uteroplacental perfusion. Answer: A, C, D, F. Rationale: resuscitation, blood products, fetal monitoring, and positioning are immediate priorities. Manual placenta removal is not routine for antepartum hemorrhage and requires appropriate context. Surgical consultation should not be delayed if unstable. Strategy: in major bleeding, prioritize resuscitation plus fetal assessment plus timely intervention. Question 36. Which are signs of severe dehydration and electrolyte imbalance in pregnant clients with prolonged vomiting? Select all that apply. A. Low urine output and concentrated urine with high specific gravity. B. Orthostatic hypotension with tachycardia. C. Increased skin turgor and peripheral edema. D. Metabolic alkalosis from loss of gastric acid, vomiting. E. Normal serum potassium despite repeated vomiting. F. Elevated BUN and hemoconcentration, increased HCT. Answer: A, B, D, F. Rationale: vomiting causes volume depletion, low UOP, orthostatic changes, hemoconcentration, elevated BUN, and metabolic alkalosis. Potassium is often low, not normal, due to losses. Increased skin turgor/peripheral edema are dehydration contradictions. Strategy: when vomiting is severe, monitor UOP, vitals, electrolytes, and acid base, replace appropriately. Question 37. Which are appropriate elements of labor induction counseling and preparation? Select all that apply. A. Discuss Bishop score and cervical favorability before induction decision. B. Offer induction at any gestation regardless of fetal maturity without counseling. C. Explain methods, membrane sweep, oxytocin, cervical ripening agents, and risks/benefits. D. Ensure informed consent and discuss likelihood of cesarean if induction fails. E. Avoid continuous fetal monitoring during induction with oxytocin. F. Monitor uterine activity and adjust oxytocin per protocol to avoid tachysystole. Answer: A, C, D, F. Rationale: Bishop score guides induction success, discuss methods, risks, consent, and potential for C-section. Continuous fetal monitoring is recommended during oxytocin infusion to monitor for tachysystole and fetal distress. Induction should follow assessment of fetal maturity and indications. Strategy: induction requires informed consent plus monitoring plus preparation for escalation. Question 38. Which are warning signs of peripartum cardiomyopathy in late pregnancy or early postpartum? Select all that apply. A. New onset dyspnea at rest or with minimal exertion. B. Orthopnea and paroxysmal nocturnal dyspnea, PND. C. Peripheral edema and jugular venous distension. D. New systolic murmur that resolves within 24 hours. E. Rapidly falling hemoglobin without bleeding. F. Persistent cough with pink frothy sputum. Answer: A, B, C, F. Rationale: peripartum cardiomyopathy presents like heart failure, dyspnea, orthopnea, edema, JVD, pulmonary edema, pink sputum. A transient murmur or falling hemoglobin without bleeding are not classic indicators. Strategy: new cardiopulmonary symptoms near-term/postpartum evaluate for cardiomyopathy/heart failure. Question 39. Which factors warrant immediate neonatal resuscitation at delivery? Select all that apply. A. No spontaneous respirations at birth. B. Heart rate less than 100 beats per minute. C. Good tone and crying vigorously but cyanotic hands/feet, acrocyanosis. D. Meconium-stained fluid but vigorous newborn with strong respiratory effort. E. Floppy, pale infant with poor respiratory effort. F. Active movement and good cry with heart rate greater than 120. Answer: A, B, E. Rationale: absent respirations, bradycardia less than 100, and poor tone/respiratory effort require resuscitation. Acrocyanosis and vigor with meconium in a vigorous infant often need observation only. Strong cry and high HR indicate stabilization. Strategy: use breathing, airway, chest compression steps guided by HR and respirations. Question 40. Which clinical features suggest amnionitis/chorioamnionitis in a laboring client? Select all that apply. A. Maternal fever greater than 38 degrees Celsius 100.4 degrees Fahrenheit with uterine tenderness. B. Foul-smelling or purulent amniotic fluid or vaginal discharge. C. Fetal tachycardia greater than 160 bpm sustained. D. Maternal leukocytosis and maternal tachycardia. E. Presence of prolonged rupture of membranes, greater than 18 hours, prior to labor onset. F. Clear, odorless fluid and normal maternal temperature. Answer: A, B, C, D, E. Rationale: chorioamnionitis commonly shows fever, uterine tenderness, foul fluid, fetal tachycardia, maternal leukocytosis/tachycardia, and prolonged ROM increases risk. Clear odorless fluid and a febrile mother suggest no infection. Strategy: with fever plus uterine tenderness plus fetal tachycardia treat for chorioamnionitis. Question 41. Which maternal conditions are associated with polyhydramnios? Select all that apply. A. Fetal gastrointestinal obstruction, e.g., esophageal atresia. B. Maternal poorly controlled diabetes mellitus. C. Oligohydramnios due to fetal renal agenesis. D. Multiple gestation with twin-to-twin transfusion syndrome. E. Postterm pregnancy with decreased fetal urine output. F. Maternal antihypertensive use causing decreased uterine perfusion. Answer: A, B, D. Rationale: polyhydramnios is linked to fetal swallowing problems, GI obstruction, maternal hyperglycemia, polyuria in fetus, and twin-to-twin transfusion. Oligohydramnios and decreased fetal urine output cause low fluid, not polyhydramnios. Antihypertensives causing decreased perfusion relate more to oligohydramnios. Strategy: when AFI is high, evaluate fetal anomalies, maternal glucose control, and multiple gestation issues. Question 42. Which are safe and recommended practices for exercise during pregnancy for most low-risk women? Select all that apply. A. Aim for 150 minutes/week of moderate aerobic activity if tolerated. B. Avoid activities with high fall risk and direct abdominal trauma. C. Start vigorous high-impact training abruptly without prior fitness baseline. D. Stay hydrated and avoid overheating, especially in the first trimester. E. Use supine position for exercises beyond 20 weeks to maximize comfort. F. Stop and seek care if vaginal bleeding, dizziness, or decreased fetal movement occur. Answer: A, B, D, F. Rationale: moderate regular exercise is encouraged, avoid risky activities, prevent overheating, and stop for warning signs. Supine exercise is discouraged after mid-pregnancy due to supine hypotension. Starting vigorous workouts without prior conditioning is not advised. Strategy: encourage regular, moderate, safe exercise and avoid extremes. Question 43. Which lab findings and signs indicate DIC, disseminated intravascular coagulation, in obstetric patients? Select all that apply. A. Prolonged PT and APTT with elevated INR. B. Low fibrinogen and elevated D-dimer. C. Thrombocytopenia with bleeding from 4 sites and gums. D. Hemoglobin that is stable despite active bleeding. E. Microangiopathic hemolysis on peripheral smear. F. Elevated platelets and clotting factors due to inflammatory response. Answer: A, B, C, E. Rationale: DIC shows prolonged clotting times, low fibrinogen, elevated D-dimer, low platelets, bleeding, and hemolysis. Hemoglobin typically falls with bleeding, platelets and clotting factors are consumed, not elevated. Strategy: in obstetric emergencies, abruption, AFE, retained POC, think DIC and correct coagulopathy promptly. Question 44. Which maternal symptoms strongly suggest uterine rupture during trial of labor after cesarean, TOLAC? Select all that apply. A. Sudden abdominal pain and loss of contraction pattern. B. Vaginal bleeding and sudden fetal distress, bradycardia. C. Palpable fetal parts high in abdomen change in station. D. Gradual, predictable progress of labor with increasing dilation. E. Sudden cessation of fetal heart tones on monitor. F. Increased maternal heart rate and hypotension. Answer: A, B, C, E, F. Rationale: uterine rupture presents acutely with severe pain, bleeding, loss of uterine tone/pattern, fetal distress or loss of fetal heart activity, and maternal hemodynamic instability. Fetus may be palpable through the abdomen. Gradual predictable labor progress is opposite of rupture. Strategy: any sudden severe pain plus fetal compromise in TOLAC, suspect rupture and prepare for emergent laparotomy. Question 45. Which are true regarding breech presentation near-term and management options? Select all that apply. A. External cephalic version, ECV, at 37 weeks may be attempted if no contraindications. B. Elective vaginal breech delivery is always preferred over cesarean for all breech fetuses. C. Contraindications to ECV include placenta previa and oligohydramnios. D. Multiparous women with frank breech and experienced providers may be candidates for vaginal breech delivery. E. Breech presentation guarantees neonatal neurological injury regardless of delivery mode. F. ECV success is higher when performed earlier in labor, after membranes rupture. Answer: A, C, D. Rationale: ECV can be offered near-term if no contraindications, e.g., previa, oligohydramnios. Some multiparous women under strict criteria may have vaginal breech delivery, however, elective cesarean is common. Breach does not guarantee injury. Timing for ECV is before labor with intact membranes, not during/after rupture. Strategy: consider ECV and individualized delivery planning based on risks, provider skill, and patient preference. Question 46. Which are maternal/neonatal risks associated with opioid use disorder in pregnancy? Select all that apply. A. Increased risk of preterm birth and low birth weight. B. Neonatal abstinence syndrome, withdrawal, after birth. C. Decreased placental abruption risk due to opioid vasodilation. D. Higher rates of congenital structural malformations universally across all opioids. E. Need for coordinated care with addiction services and neonatal team. F. Continuing MAT, medication-assisted treatment, like methadone or buprenorphine is often recommended rather than abrupt cessation. Answer: A, B, E, F. Rationale: opioid use disorder increases preterm birth and NAS risk. Coordinated addiction and neonatal care is essential. MAT continuation is recommended, abrupt cessation is risky. Not all opioids universally cause structural malformations. Abruption risk is not decreased by opioids. Strategy: manage substance use in pregnancy with harm reduction and coordinated care. Question 47. Which findings in the first trimester would most strongly suggest abortion? Miscarriage is in progress? Select all that apply. A. Passage of tissue and clots with decreasing abdominal pain. B. Heavy bleeding with cramping and an open cervical OS on exam. C. Closed OS with persistent mild brown spotting and stable vitals. D. Ultrasound showing absence of fetal cardiac activity meeting criteria. E. Sudden cessation of bleeding and resolution of pain with persistent pregnancy test positivity. F. Rising quantitative HCG consistent with normal doubling. Answer: A, B, D. Rationale: passage of tissue, heavy bleeding with open OS, and ultrasound confirming lack of cardiac activity indicate ongoing or completed miscarriage. Closed OS with little spotting may be threatened and requires follow-up. Rising normal HCG suggests ongoing viable pregnancy. Strategy: combine clinical exam, HCG trend, and ultrasound to determine miscarriage status. Question 48. Which are appropriate discharge instructions for a woman who had vaginal lacerations repaired after delivery? Select all that apply. A. Use sitz baths and keep perineal area clean and dry. B. Avoid heavy lifting and strenuous exercise until healed. C. Expect large clots and soaking a pad every 15 minutes as normal. D. Use stool softeners to prevent straining during bowel movements. E. Report fever, increased pain, or foul odor from wound site. F. Return to sexual intercourse as soon as lochia stops, regardless of healing. Answer: A, B, D, E. Rationale: sitz baths, hygiene, activity restrictions, stool softeners, and reporting signs of infection are appropriate. Excessive bleeding soaking pads every 15 minutes is abnormal and requires urgent care. Sexual activity should wait until healing and provider clearance. Strategy: encourage wound care, infection surveillance, and gradual return to activity. Question 49. Which are correct about Rh incompatibility and prevention? Select all that apply. A. Give Rho, D. Immune globulin, Rhogam, to an Rh-negative unsensitized woman at 28 weeks. B. Administer Rhogam to an Rh-negative woman after any potential sensitizing event, e.g., miscarriage, amniocentesis. C. If the mother is Rh-negative and baby Rh-positive, the newborn will always suffer severe hemolytic disease regardless of prophylaxis. D. Perform indirect CUMS, antibody screen, early in pregnancy to detect maternal antibodies. E. Rho, D. Immune globulin is contraindicated in women who are already sensitized, CUMS positive. F. Maternal Kleihauer-Betke or Rosette test may be used to quantify fetal maternal hemorrhage after delivery to determine Rhogam dosing. Answer: A, B, D, E, F. Rationale: Rhogam is given at 28 weeks and after sensitizing events. Early antibody screen is routine. Rhogam is not given to women already sensitized. Post-delivery testing helps calculate additional Rhogam dosing. If properly managed with prophylaxis, severe hemolytic disease can often be prevented. Strategy: prevent sensitization with timely ROGAM and antibody surveillance. Question 50. Which are appropriate components of antenatal fetal surveillance for high-risk pregnancies? Select all that apply. A. Non-stress test, NST, for fetal heart rate reactivity. B. Biophysical profile, BPP, combining NST with ultrasound assessment. C. Kick counts, maternal fetal movement counting, at home for decreased movements. D. Daily routine NSTs for all low-risk pregnancies starting at 20 weeks. E. Doppler ultrasound of umbilical artery for suspected placental insufficiency. F. Amniocentesis for genetic testing without counseling or informed consent. Answer: A, B, C, E. Rationale: NST, BPP, kick counts, and Doppler studies are standard surveillance tools for high-risk fetuses. Routine daily NSTs in all low-risk pregnancies are not indicated. Amniocentesis requires informed consent and counseling due to risks. Strategy: tailor surveillance modality to the risk, NST/BPP/Doppler as indicated, and ensure informed decision-making. Great job making it through all 50 tough SATA pregnancy questions. Remember, the NCLEX is not about memorizing, it's about understanding concepts and applying them in real-life scenarios. If you found this helpful, don't forget to like, subscribe, and hit the bell so you don't miss our next NCLEX practice session. Share this with your study group and keep practicing, because every question you tackle brings you one step closer to becoming an RN. Thanks for watching, and until next time, stay motivated, stay confident, and keep studying smart. You've got this.